it's ready to start.
Yep, I can start.
Yeah.
Apologies, Henry's already listened to this. So
That's okay.
Yeah, maybe Henry could introduce Rachel better than I can.
Yeah, I mean, Rachel's a research associate working with Professor Angela Webster in Sydney, and she's done some really interesting work looking at non-utilization of these donor kidneys using
Yep.
national data. So, Rachel.
Yeah,
go for
thank
gold.
you. Thank you. Yes, hi, I'm Rachel. I work with Angela Webster at the CODE Lab, so it's Centre for Organ Donation Evidence here at University of Sydney. So I'm going to be presenting our study, non-retrieval and non-utilisation of deceased donor kidneys for transplantation in Australia. So we know that there is an imbalance in the supply and demand of donor kidneys globally. So there are more people waiting for a kidney transplant than there are the supply of donor kidneys. So our prior work has shown that in New South Wales, at the end of 6 years from entering the waitlist, 5% of people died while waiting for a transplant and 16% remained waiting. And this shows the impact of the imbalance of supply and demand. So how do we increase kidney transplant opportunities for Australians waiting for a transplant? In Australia, the deceased donation pathway consists of 3 sequential stages: becoming a potential donor, intended donor, and actual donor. While our other work has focused on missed opportunities from potential and intended donors that did not proceed further due to biovigilance concerns, the study I'm presenting today is investigating kidneys that are either not retrieved or not utilised from actual deceased donors. In Australia, actual donors are defined as individuals for whom organ procurement has commenced in the operating room with surgical incision for the purpose of transplantation, regardless of whether the organ was retrieved. So to break it down a bit further, we are interested in donors that were incised in the operating room, but their kidneys were not retrieved, which we call non-retrieval, or kidneys retrieved from the donor's body, but subsequently not utilised, either shortly after retrieval, during transport, or at the recipient's facility. And this is called non-utilisation, or sometimes referred to as discard. So our study objectives were to quantify non-retrieval and non-utilisation of kidneys from actual deceased donors in Australia and to determine the associated donor and system factors. Our secondary aim was to describe the reasons for non-retrieval and non-utilisation and identify potential health service interventions to improve kidney utilisation. So we used de-identified data from the Australia and New Zealand Organ Donation Register, ANZOD. Our study consisted of all actual deceased donors in Australia from 2014 to 2021, and we looked at kidney donation only, so including single kidneys, dual allocation, and en bloc. And dual allocation and en bloc are when 2 kidneys from one donor are retrieved and transplanted into one recipient, and we counted these kidneys as one organ in our analysis. So we investigated both donor and system characteristics, which are listed here. Our system characteristics were limited due to data restrictions. So for example, we could not access identifiable facility information, which limited our analysis to state and territory facility locations only. So there were 7,229 kidneys intended for retrieval from a total of 3,683 actual donors, and we excluded 18 single kidneys with the primary intention for research, and the remaining 7,211 were included in our analysis. So among the 7,211 kidneys intended for retrieval, 675 were not retrieved, which was 9%. And of those kidneys retrieved for transplantation, 430 were not utilised. So the non-retrieval rate in pink increased on average 0.7% every year from 5% in 2014 to 10% in 2021. And the non-utilisation rate was relatively stable, increasing on average only 0.4% per year from 6% in 2014 to 8% in 2021. And the yellow highlight, if you can see it, shows the COVID-19 period And you can see that there is a peak in the non-retrieval rates in 2020, and this may be attributed to the impact of the pandemic, as adult kidney transplants were suspended for a month or so in March in 2020. And then we looked at KDPI and found some evidence of changes in the non-retrieval rate over time. So the average annual increase in the non-retrieval rate for KDPI over 75% was 1.8%, whereas for KDPI less than 75%, it was 0.3%. And the changes in the non-utilization rate remained consistent across KDPI levels. So looking at the factors associated with non-retrieval, which is shown in the left column, we found KDPI over 75% was strongly associated with non-retrieval for both standard criteria and extended criteria kidneys, as well as donors with diabetes and history of cancer. In the opposite direction, factors associated with a higher likelihood of retrieval included donors being obese. And we found the non-retrieval rates varied by donor hospital states. So for example, New South Wales had lower likelihood of non-retrieval compared to other states. And we also saw that it varied over time with the later era, 2018, whoops, I just go back, 2018 to 2021, having high odds of non-retrieval compared to the earlier era. So factors associated with non-utilization in the right column included DCD, history of cancer, and older age. So looking now at the reasons for non-retrieval, we mapped national disposition codes and free text descriptions to main reasons. And the graph on the left shows the main reasons for non-retrieval, and the table on the right shows the breakdown of each main reason. And as you can see, disease of organ was listed as a reason 248 times, although the disease wasn't specified. And there were times when there was no information on why the organ wasn't retrieved. As you can see, not specified, also highlighted in yellow, is listed 76 times. And other reasons were a bit more obvious, included cancer risk and viral risk. So for system characteristics, the main reasons for non-retrieval were quite vague, with no suitable recipients followed by decline in offer process. And reasons for non-utilization by donor characteristics were again risk other, followed by perfusion issues, where 74% were DCD. For system characteristics, the main reasons for non-utilization were no suitable recipient, followed by trauma to organ. So in summary, in Australia, annual non-retrieval rates of deceased donor kidneys are increasing and have doubled in 8 years, reaching 10%, while non-utilization rates remain stable around 7%. Non-retrieval is 3 times more likely for kidneys with KDPI over 75% compared to KDPI less than 25%. And this highlights the potential for targeted efforts to maximize utilization of kidneys with KDPI over 75% where possible. And perfusion issues, particularly for DCD, emerged as a primary reason for non-utilization, and this finding supports the implementation of enhanced perfusion techniques. But more transparent and specific data collection is needed, so especially regarding reasons, as currently the data does not provide enough clarity to gain insights into to optimize kidney utilization. And thank you very much for listening to my presentation. I think we have some time for the discussion. Oh, yes, Santosh. Just me.
Yeah, thank you, Rachel. That was a nice presentation. This is a usual problem in kidney transplant as well as in liver transplants that we often see. Now, I'm just curious to know that, see, these days our extended criteria donors supply seems to be increasing. And in fact, in the last 3 months here in South Australia, we've used more DCD donors than DBD donor kidneys. Now, how many of these patients, these organs have been discarded or decided not to retrieve because of imaging do you do routine imaging? What was it that you found? Did people use routine imaging for all these organs?
Sorry, imaging. What do you
Yeah,
mean by imaging?
imaging before donation. What was the usage of imaging, like CT imaging? Because I know the cardiothoracic teams would usually ask for some sort of CT imaging of the heart, lung. But how often did you see imaging of the abdominal organs? And therefore, people decided they're going to not retrieve these organs or not use these organs by imaging alone.
I
Do you
don't think.
do you want some help, Rachel?
Yeah, I can't recall if there was that as a reason. I'll just
Because all of
share
these,
this.
all of these people all of these donors that we're reporting here all made it as far as the operating theatre.
Yeah,
So any imaging would have been prior to the decision to take them there.
that's what I
So
thought. Yeah.
they all made it as far as the operating theatre and actually were all incised as well. So imaging would have been before the fact. So there would have been little that would have. There's no imaging after they've been brought to theatre and incised. So, and in terms of routine imaging for kidney donation, there isn't anything routine. Occasionally, we might ask for things depending on the mode of death. We might ask for, if there's trauma, for instance, there might be an ultrasound or a CT's usually been done already, but there's nothing specific for kidneys. Does that help?
Yeah, thank you. But this is something that we have this ongoing discussion in South Australia, whether to make this ECT imaging in extended criteria donors as mandatory. Because when we, often we find surprises at the time of the retrieval, and it's always best practice in a way to figure out how many vessels these organs have and so on and so forth. And therefore, the planning is much more better, especially when we go in for DCD donors. So that was a suggestion. And that is the sort of line of thinking we have here in South Australia.
Mm.
Yeah, I don't know what you think, Henry. Sometimes sometimes there's no time. Sometimes it's difficult to justify if it's not going to change how you proceed. I think that's how we feel. And also, you don't want to put more barriers in the way of families having to wait anyway. What do you think, Henry? Were you going to say
Yeah,
something?
I was going to say, I think that there's possibly an argument for the liver, but I think obviously what you're suggesting is doing a CT angio. If you're trying to identify how many vessels a kidney has, and I really want to do a CT angio in a potential donor, that's just a contrast load you don't need. I can say that in 30 years, well, actually 32 years of doing organ donation, I have discarded or non-utilized 2 kidneys because they had polycystic kidney disease, which was previously unknown, but that's 32 years worth of doing a lot of donors. So I really wouldn't advocate doing a CT scan just for a kidney donor. I think, yeah, we can obviously delay the donor. I mean, it is a common problem. The cardiac surgeons often want imaging of the chest. And certainly if you have a donor that's a liver-only donor in, a far-flung, hospital that needs a plane to get there, then potentially, obviously, doing a CT scan would absolutely exclude that liver donor as a single organ donor. But I really can't see the value of doing a scan for kidneys. I think it's often the final straw, isn't it? I mean, you've got a very high KDPI donor, as it were. So, if you do a CT scan and it shows 2 cysts in the kidney, that's just probably enough for someone to say, I'm not going to bother. Is that useful? I would argue it's not useful. But it's open for debate. Everyone has their own viewpoint. Sorry,
I would argue a bit differently, Henry.
Yeah.
Especially when we have the heart lung guys coming and asking for a CT, and the ICU kindly obliges to have a CT chest, it wouldn't take 10 seconds extra to run the CT down to the abdomen as well. And that, in a way, I think
yeah,
will definitely help.
absolutely. It doesn't add time. It's just you're actually encouraging this behavior so that every donor will end up getting a contrast load. I think that just often delays it to the next 24 hours, and it is not helpful for the kidneys. But Yeah, absolutely. If it's going to be done, it makes no difference. I agree in terms of time. But you're just promoting, I think, something that isn't actually helpful for the renal organ. But anyway, that's just my feeling.
Thanks, Henry. I think Handu.
Yeah, thank you. I just wanted to ask about the data. So I imagine that we would have had a bit of a change in practice over the last 10 years. I mean, unlike Henry, I've only been practicing for about 10 years or so. And even in my short time, I've noticed, the KDPI of our donors are rising. And we often have discussions before retrieving, and people would, as a group discussion, we would say, oh, look, this patient's pretty marginal, recipient's marginal. If there are issues during your perfusion, let us know. And as a result of it having high KDPI, you often have calcified vessels from smokers and those with diabetes or mild diabetes or hypertension. So I imagine some of what we're seeing is a trend in patient characteristics. But yeah, would love to know if you have much thought on it.
Yeah, I agree. So we did see that rise in the non-retrievals, and it was seeming to be driven by the high KDPI kidneys over time. But I guess there always has to be a balance between, there's obviously cases where you can't retrieve these organs or you can't utilize these organs. So there's always going to be some number of that happening. But then it's just, can we optimize it? Can, the ones that we're not retrieving or not utilized, is there something that we can change in the system or the techniques used to be able to try and, reduce the wastage, I suppose. But yeah, there will always be cases where you can't utilize, because the decision to not utilize an organ has to be made during that time when you actually see the organ or when it's going into the recipient at the other end as well. So hopefully that answered.
There's a few people with their hands up. Henry's still got his hand up. Did you mean to?
Yeah, I did. I just had a thought, really thinking about Handu's comment there, because over my lifetime, we've really changed. We almost accept any potential donor, whereas, you would have laughed at that 25 years ago. I just wonder, Rachel, whether have you been able to break down kidney-only donors and whether they had a much higher, either, not retrieval or discard rate? Because obviously they're the worst of the worst. If you're actually not retrieving any other organ from that donor, you're only going for. Do they have a much higher,
I haven't looked at kidney. I haven't looked at that yet. But thank you for suggesting. I will have a look. So that you expect that they'd have a higher non-retrieving?
I would do, because obviously the liver's not usable. The heart and lungs aren't usable just on paper. So literally, you're only retrieving the kidneys. And of course, maybe, Santosh's comment is maybe we should be perhaps targeting that group. If you show that they have a higher discard rate, how can we do better? I mean, I suspect they're just very, very marginal. And then the final straw is you've got a very, diseased aorta, diseased renal artery, and poor perfusion or something like that. But I'm not sure that scanning would make any difference, because they're still going to be awful on paper. But it'd be interesting to look specifically at just kidney-only donors to see if it's any difference. Yeah, I hadn't had a thought of that, but just occurred to me.
Sure. Marcus.
Hi, Rachel.
Hello.
Great work. Congratulations. So maybe I missed at the start. So have you worked it out? So these kidneys they didn't go to the machine perfusion, I assume. That's pre-machine perfusion.
So
you
the
don't
first...
in any of these centers. So you are discarding the kidney when you retrieve them or before you look at them?
Yep. So we've got two groups. So one is, if I can go back to this, might be helpful.
And
oops. So this is the ones where we've grouped it as non-retrieval. So they've been incised, they've been taken out of the body. They've they haven't been taken out of the body, but they've
They
been
haven't been
incised.
taken. All right.
No. But this one is that the non-utilization is that they have been retrieved from the body and then not utilized after that.
So, and no, the ones that have been retrieved out of the body and hasn't been utilized and haven't been utilized, have any of them gone to the machine perfusion, hypothermic? You don't have the data.
I'd have to.
We don't know. I don't think we know what. We
No.
don't have that data. They haven't provided data to us about whether or not they had additional support, like machine perfusion, warm or cold.
Okay.
I do know the reasons. The reasons were for the non-utilization, where perfusion issues was the second most commonest reason. If that's at all helpful.
Yeah, just because your work could be the basis for something that's going to be built up in the future when we have all the machine for all the transplant centers. Yeah, that's just a comment. Thank you.
That's okay. I think Santosh had another question.
Yeah, I think, Rachel, my question was more in the line of like what Marcos was asking. Like, what is the criteria that the surgeons who said that, okay, these DCD kidneys, the perfusion is bad and therefore decided to say no? Was there any particular criteria that they used, or they just said, oh, it is not flushed properly, it's still warm blood in there, we will not use it? Because the reason is that it's not as clear as you just allocate 1, 2, 3 to 10 marks to that particular perfusion. We don't do that. It's either good, it's like one look, no good. Or what is the criteria that they use? Because that then only this data makes much sense
That's right,
to me. Yeah.
No, the data, like I said, it's not very easy to interpret. And so what we received was data that had some main reasons, like disease of organ, and then there was like a free text variable where some surgeons would have put in more specific information. So some of the ones with perfusion issues, they would specify in the free text was not able to flush, etc. But it wasn't consistent. So some would just say, perfusion, that's it. And others would have a little bit more information. But in terms of the criteria, I didn't have any of that type of information at all. So I think one of the findings from this is also that we definitely need to improve this type of data so we can have a much better understanding, because as it currently is, it's not very helpful. And some of the reasons I'm not really sure how that happened. For example, some with viral risk, and I wonder how that happened at that point in the retrieval process, if they were getting information a bit later. And that's why, they decided not to go ahead with it, because they suddenly found out, oh, this kidney might have HIV or something like that.
Because
But it's really hard to know currently.
I sort of agree with what Marcos says. This probably is like a stepping stone to to ensuring that all these kidneys go into some sort of a pump, and then see how these kidneys, these organs do. Because in reality, what normally happens is that, say, if you are you're cannulating the aorta with a lot of atheromatosis disease, a shower of emboli go through, and usually the liver catches most of it, and often the liver guys will say, no, we don't want that organ. But however, in the kidney scene, what we do see is that, we do find some ecchymotic or emboli there, but often we do use it, and I found that these kidneys do well too. So so it is like it's not entirely very clear what would have happened if these kidneys were transplanted. So maybe, as Marcos suggested, maybe pump is the way to go for all these organs.
I mean, what struck me when we were doing this analysis and Rachel was bringing this together was when we looked back, someone had done an analysis that was similar but not looked at the non-retrieval back in 2019. And one of their main conclusions is that the data points are rubbish and we need to do better in collecting the reason that we don't use these organs. And nothing's changed. And we're now, probably a good 8 years later from the end of that data set to what we've done now. And you still look, risk other is still there. That's completely unhelpful to know risk other. And when we look down the list of that, then something like, you know, not specified is 40% of those, and 40% overall of the non-utilization reasons. So we're not even capturing, it's really hard to guess what's going on, because the way that the data is captured and the taxonomy that's used doesn't meet the needs of us trying to audit or look at the governance of this, because we just don't know what's going on. And similarly, you know, disease of organ, you might not know before you got there, but there's a lot of other reasons here which is just kind of a bit odd and a bit unusual. Like post biopsy not specified 10%, not specified at all 40%. That's 50% of the non-utilized organs. We don't know why. And I think we could change that. Pressure from us could change that, because, you know, ANZOD should do better with this, I think.
I think Henry had his hand up for a while.
Yeah, it was just a comment. I mean, you know, poor perfusion is very subjective, and I'm sure every state is the same. We have our DDoPS committee that will go through every single non-utilized kidney. Then that's also discussed at the surgeons donor coordinators meeting as well, through every state again. You can't put a number on it. We decided in New South Wales we'd have at least 2 doctors decide whether a kidney is not utilizable. So it's not just on the basis of one person's opinion. But it's not very scientific, Santosh, and it's kind of, it is difficult, but from my own experience, if the kidney's full of blood, despite spending litres and litres of fluid through it, and it doesn't change, then we wouldn't transplant it. But I agree, you know, there's that some areas that are okay, then, and if it's a great young person's DCD kidney, they'll absolutely use it. So I think these are very subjective decisions. So I suspect you're right. Out of those that were discarded and returned to the body or cremated or whatever, there's going to be some of those that would have been very transplantable, is my guess. We haven't found, you know, in the literature that normothermic machine perfusion is a useful assessor of that. In fact, Osgood and Nicholson didn't show any significant benefit of that technology in terms of increasing the utilization rate. So I think it's interesting. Hundu, in Queensland, have you discarded a kidney on the basis of your hypothermic machine perfusion?
I have to say we haven't. We have discarded after retrieval. Yeah. So you know, based on a subjective view, but I mean, we have done a fair bit of analysis on the machine to see if it would predict poor outcome, and there's only very weak association from our experience. So based on our machines, I'm not sure if we could reliably discard based on the kinetics.
Yeah, I think you know, we tend to decide on the macroscopic appearance, don't we? If it's still full of blood. I think it's a lovely thought to think that you can, you know, further wash blood out, and I think what does happen is sometimes it does get washed out just with time, you know, when the vasospasm wears off from a DCD donor. So I think maybe we perhaps discard too soon if it's an otherwise great kidney. But yeah, no, I definitely agree with Angela's feeling that we don't have the detail currently to know why are not used. I've certainly been aware of a Hep C donor or donors where ultimately the donor's gone ahead and then the nephrologist caring for the recipient says, "Oh, I don't want to take the risk. I don't want to give my recipient Hep C." So then it's been abandoned. So that absolutely has happened in New South Wales, and I think it's happened more than once, which is very frustrating. You know, when it's been a rare blood group and there's no other suitable recipient. So that's definitely happened more than once in New South Wales. So it's not usually the risk of HIV, you know, suddenly discovered after the donors happened.
Okay. I think Belang has had his hand up for a while.
Yes, thank you, Richard. I think you look at the confounding factor KDPI. Have you stratified the severity of the AKI and any hazard ratio on that? I might have missed some of your presentation.
That's okay.
So that's AKI. I don't know. That's the creatinine level, Rachel. The terminal creatinine. I don't think we've got, I don't think we've looked at that. I don't know if we've even got the data actually. Do you know, Rach?
The creatinine, yes.
Yeah, so the
creatinine.
terminal creatinine, the last creatinine, that's how we'd measure the AKI.
Yeah,
we don't have any data on oliguria or anything like that. We just have a terminal creatinine.
Yeah, terminal creatinine. So that's how we were able to we just have a look at KDPI, as you can see in this.
No, you're talking about AKI, which is acute kidney failure. So
oh, sorry, I thought you said KDPI.
No, AKI. That's what you said, isn't it? I think. So we can't.
You look at KDPI. Sorry, you look at the KDPI.
Yeah.
But the most donors that will have a terminal creatinine level as well, potentially indicate AKI. The level of AKI sometimes it can be one of the confounding factor,
Although
for
normally,
discard or non-utilized. Yeah.
Yeah. Although normally, if you're going to go and get the kidney, the AKI is pre-existing. It wouldn't stop you retrieving or utilizing. I don't think. It might resolve in primary non-function and explant, but it wouldn't. I agree with you, but normally if you're going to go ahead with an AKI kidney, then it shouldn't stop you, I don't think, at the point of retrieval, because the proof's in the pudding afterwards, isn't it? It's whether it recovers.
Yeah, in theory, AKI should not stop you doing retrieval, but that could be one of the confounding factor when you look at the more details. Yeah. Okay, thank you. That's good.
I think Santosh had a question.
Yeah. So, Rachel, this is getting interesting because I think the more and more I get the impression that everybody knows, wants to know more details. Because there are a lot of donor factors, there are recipient factors, there are so many variables, and we are finally in the spare parts business, and we would like to know everything about the organ. So, all the more reason whether the patient is in AKI or not, we like to know whether there's blood going through that kidney. So, CT imaging does help. In fact, we had that issue in COVID. We had a nephrologist sending us down to do a retrieval, and it so happened that the cardiac team had done a scan for the heart lung, and apparently the dye had gone into the kidney, and realized that it was a dead kidney. There was no perfusion at all. So in a way, we would like to know everything about the organs that we take out, and rest everything. I'm sure. I think we'll all find a way of figuring out what is the best organ to use.
Yeah, so it's a shame we don't have the data, unfortunately. Don't have that much information.
All right, Rachel, thank you very much for coming here today and presenting.
Thanks for inviting us.
Thank you very much. You are more than welcome to stay. We're going to talk about normothermic liver perfusion if you want to listen about it. So I would like to
finish cooking my dinner, but thank you so much.
Yeah, thanks so much.
Thank you. So I would like just to acknowledge the traditional owners of the land on which we work and pay our respects to the past, present, and elders. And emergent, sorry. So to thank you, Dr. Akinori Maeda, for coming here today. Dr. Maeda is a PhD student here at Austin Hospital, and he's going to talk about perfusate hemoglobin during liver normothermic machine perfusion and liver injury. Thank you, Aki.
Yep. Sorry, it becomes a little bit strange.
No, you are.
Is it all right?
Yeah, we can see.
Okay. So good evening, everyone. Thank you for introducing me. My name is Aki, and I'm a research fellow at Austin Hospital. And thank you for today's opportunity to present our project on perfusate hemoglobin during normothermic machine perfusion. Compared to the first presentation, this is a kind of exploratory small number study, but which is more kind of for exploring some assessment during machine perfusion. So let's start. So, So this is today's agenda. So I will start with the background information of this project, followed by main findings, questions raised by the findings, and our upcoming plans to address those questions. I'm pretty sure that you are familiar with the machine perfusion technique, but I will briefly explain the principle of machine perfusion. So this technique aims to perfuse donated livers with oxygen, nutrients, etc. to prevent ischemia reperfusion injury during preservation. So this enables clinicians to assess livers during perfusion and longer preservation of livers. Then this leads to the acceptance of higher risk donors quite recently, like elderly donors or donors after cardiac death. And in turn, this makes the liver assessment further important. Therefore, various parameters were identified for quality assessment during machine perfusion, including lactate clearance, bicarbonate, pH, glucose consumption, bioproduction, etc. However, when we think about the principal aim of machine perfusion, it is natural to focus on the oxygen delivery during machine perfusion. So oxygen delivery is determined by various factors, including PO2, SPO2, blood flow, and hemoglobin. However, PO2 and SPO2 are already almost optimized, and blood flow is, of course, controllable, but it's depending on the blood vessels, so it's not that easy to modify. So in this regard, hemoglobin is independently modifiable by red blood cell transfusion. Thus, in this project, we focused on hemoglobin as a key component of oxygen delivery during machine perfusion. So this is an overview of our project settings. So we analyzed 23 perfused livers at Austin Hospital over 2 years, and 15 of them were transplanted. As we followed the back-to-base approach, machine perfusion was initiated at the Austin Hospital after transportation from the donor's hospital and the static cold storage. All the circuits were primed with 3 packs of red blood cells and 500 milliliters of 4% albumin, according to the manufacturer's instructions. Thus, we expect all the primed circuits to have similar hemoglobin levels. Our objectives in this project were twofold. First, we investigated the change in perfusate hemoglobin during machine perfusion. Second, we further investigated the association of hemoglobin levels with liver injury. So I'm going to start with liver characteristics. And this table describes the donor and preservation characteristics. Sorry for the busy slide. The median donor age was 47, and most of them are male. And the donor risk index was 1.8. Sorry.
10 unit. Medical emergency team towards 7 West, GenMed 2 unit.
So this is donor demographics. And we focused on the hemoglobin levels at 15 minutes after machine perfusion start. This enables early assessment of liver or intervention to the livers. So this initial hemoglobin level was 84 as the median from near the bottom. And we stratified livers with this cutoff of 84 gram per liter. Then time from withdrawal to perfusion was longer in higher hemoglobin livers. And in turn, cold ischemia time was longer in lower hemoglobin livers. Other characteristics were comparable. And next, this table describes the recipient characteristics. And recipient age was higher in lower hemoglobin livers. In turn, the NA MERS score was higher in higher hemoglobin livers. So in summary, the baseline characteristics are slightly imbalanced because the liver number is too small. But this imbalance is not direct to one direction or favoring one group. So in a sense, the risk for the liver injury can be balanced in the groups. So from this slide, I'll present our main findings. So this slide shows our first objective, the hemoglobin change during machine perfusion. So the left plot describes the hemoglobin levels before and after the initiation of organ perfusion. So it compares the hemoglobin levels of priming fluid and hemoglobin levels at 15 minutes after initiating organ perfusion. The hemoglobin levels of the priming fluid or hemoglobin levels before organ perfusion were around 110 grams per liter. And after putting the liver into the circuit, hemoglobin levels significantly decreased in all livers to a median of 84 grams per liter, which happened in 15 minutes of organ perfusion. Interestingly, hemoglobin levels after the initial decrease varied between livers. And the right plot describes a continuing change in hemoglobin levels during perfusion. X-axis is the time after initiating machine perfusion, and Y-axis is perfusate hemoglobin levels. Red boxes represent the higher hemoglobin levels, and blue represent lower hemoglobin levels. This plot shows the hemoglobin decrease in the first hour continuously, but after 1 hour, it becomes stable. And the separation at 15 minutes in hemoglobin level remained observed during perfusion. So we found that the hemoglobin level decreased during machine perfusion, and the degree of hemoglobin decrease or the hemoglobin levels after initial decrease varied between livers. So in this slide, we show the association between hemoglobin levels and perfusate liver enzymes, which is our second objective of this project. So this plot represents a change in perfusate liver enzymes during machine perfusion, with colors according to the stratification by the hemoglobin levels at 15 minutes. So blue boxes shows lower hemoglobin levels, and red boxes show higher hemoglobin levels. And the x-axis is the time after initiating machine perfusion, and y-axis is lactate, ALT, AST, or LDH level of the perfusate. As you can see, higher hemoglobin levels, which was represented by red, showed lower ALT, AST, and LDH in perfusate. And next, we investigated the association between perfusate hemoglobin levels and post-transplant recipient liver enzymes. And we observed similar findings to those with perfusate liver enzymes. So in the table, it shows that the peak ALT or AST within 7 post-operative days was significantly lower in higher hemoglobin livers, which was with hemoglobin levels over 84 at 15 minutes after initiating machine perfusion. And moreover, RE allograft dysfunction was only observed in lower hemoglobin livers. And is a right scatter plot between perfusate hemoglobin levels in x-axis and the recipient ALT or AST in y-axis. It shows an inverse correlation between hemoglobin levels and the peak ALT or AST, which further supports the advantage of higher hemoglobin. However, there was no significant difference in long-term clinical outcomes. This may be because these outcomes are strongly influenced by the recipient clinical status rather than the quality of livers. So this is a summary of findings. In summary, to the best of our knowledge, we are the first to describe hemoglobin decrease shortly after initiating machine perfusion and remained at a similar level afterwards. And also the hemoglobin levels after the initial decrease varied between livers. And higher hemoglobin levels showed lower liver enzymes in perfusate, and also higher hemoglobin levels showed lower liver enzymes and lower incidence of EAD in recipients. These novel and consistent findings indicate the potential benefit of maintaining higher hemoglobin levels during machine perfusion to help prevent liver injury. So now we move to the discussion part, including upcoming plans. So we observed the hemoglobin decrease during machine perfusion and its association with liver injury. However, these findings lead to additional questions. First, what causes the observed decrease in hemoglobin? And second, Does a decrease in perfusate hemoglobin influence liver injury or vice versa? So we don't know which comes first. So we started with the question, what causes hemoglobin decrease? All the livers were flushed with albumin before organ perfusion. Thus, the remaining albumin in liver vessels will dilute perfusate hemoglobin. Also, hemolysis is inevitable in all the machine-assisted perfusion, and microvascular trapping of red blood cells were reported in previous literatures. But further investigation still needed, including histological assessment. And another question is about the causal relationship between perfusate hemoglobin and liver injury. So we observed the association between perfusate hemoglobin levels and liver injury during preservation. However, as this is an observational study, we were unable to demonstrate any causal relationship. Thus, there are two potential pathways. First, higher hemoglobin led to better oxygen delivery and helped prevent liver injury. Second, the less injured livers resulted in less decrease in hemoglobin levels, or combination or mixture of these pathways. As the degree of hemoglobin decrease varied in livers, it means hemoglobin decrease may reflect the quality of livers, which is the second pathway we show here. But also the first pathway is theoretically quite reasonable. To prove this, we calculated the oxygen delivery by the shown equation using parameters measured during machine perfusion. The red plot shows a change in oxygen delivery during machine perfusion. X-axis is time after initiating machine perfusion, and y-axis is the calculated oxygen delivery to perfuse livers. The pink line represents the mean of oxygen delivery in higher hemoglobin livers, and these higher hemoglobin livers showed higher oxygen delivery, which was confirmed by a linear mix model. In the right scatter plot between oxygen delivery and post-transplant ALT or AST, higher oxygen delivery was associated with lower recipient ALT or AST. Taking all these findings together, maintaining higher hemoglobin during machine perfusion may be beneficial by achieving better oxygen delivery. But also, we don't know about the real oxygen consumption, so future investigation on oxygen consumption may help further evaluate the effect of oxygenation during machine perfusion. So to address these above-mentioned questions, we are preparing to conduct further investigations. First, we will measure oxygen consumption, as we discussed, during machine perfusion to further evaluate the effect of oxygenation on liver injury. Second, we will conduct a prospective trial comparing different targets in hemoglobin levels during machine perfusion to investigate the protective effect of higher hemoglobin levels on liver injury. So this is a conclusion slide of this presentation. Hemoglobin levels showed a decrease during normothermic machine perfusion, and higher perfusate hemoglobin levels were associated with lower liver injury markers. Further investigation on the effect of oxygenation, which is a key component of machine perfusion, are warranted, which will help optimize the current management during machine perfusion. Thank you for listening. Do you have any questions?
Thank you very much, Aki. A great talk. So we have Santosh and followed by Henry and Handa. Hey, Santosh, go ahead.
Yeah, thank you, Aki. That was a nice presentation, interesting. Now, with the data, how long have you followed up these livers for? Because you said that there's not been much of long-term results are satisfactory, something like that you said. So I'm just wondering, in terms of biliary strictures and all that, how long have you followed up these patients for?
So, our observation period is from 2020 to 2022. So we can observe at least 1 year for all patients. So all the patients, most of the patient was alive, and we also investigated the biliary stenosis, but we couldn't find any significant difference. This can be because we have very small number of patients, so we are not enough powered, but as a result, we couldn't find any significant difference.
Thank you.
Yeah, great talk. I had a couple of questions. The first was, did you look at the liver volume, and did that have any impact on the drop in hemoglobin? Because I guess a larger volume liver would have a larger sort of dead space, which you said was primed with albumin. So that was my first question. But then what about the 8 livers you didn't transplant? Did you see a trend in their hemoglobin on the machine perfusion? So you had 8 livers out of the 23, didn't you, that you didn't utilize?
Thank you for the question. So the first thing is about the liver weight. So actually, not all the livers are weighted before the transplantation, but among the livers which was weighted, or we can estimate the liver weight by the liver volume, we calculated the AST or ALT divided by liver weight. And it shows the correlation, actually more strong correlation with the hemoglobin levels. And also we tested the association between the hemoglobin levels and liver weight. I didn't show in this presentation, but it has no association. But the number is really small, so we cannot say kind of conclusive things, but we didn't observe any relevant findings. And about the 8 rivers, it is a bit tricky, and also I didn't show in this presentation, but as you told, so among the 23 rivers, 15 was transplanted and 8 was discarded. And we checked the hemoglobin levels of 8 discarded rivers. And actually, it was a kind of middle of the livers with EAD and rivers without EAD. So it can mean that among the discarded rivers, some of them can be transplanted. So it becomes middle of the livers which showed EAD, area graft dysfunction, and livers without area graft dysfunctions. Does it make sense? Sorry for not good explanation.
Well, you're saying that you can use the hemoglobin as a marker for utilization. So I guess that's a bit of a stretch, I would say, but possibly. But if you're an optimist,
Yep.
I mean, it was a really great presentation and a fascinating bit of work. I wondered whether, because my initial thought listening to your talk, I was thinking, well, if you got a very, I guess, on reperfusion with your packed cells, if you then inflame that liver with that reperfusion syndrome, you'll actually get a lot of fluid sort of adding to your circuit, and therefore your hemoglobin will drop. So you can logically assume that it is a marker of inflammation, which then transcends to, higher transaminases. So it all makes some logical sense, but I'm not sure that just, bumping up the hemoglobin will prevent that problem. So, I mean, I guess that's your next bit of research, isn't it? But one would assume it wouldn't make any difference.
Yes, I totally agree with you. So we don't know which comes first, actually. So it can be a kind of marker of the liver quality. And also, we hope it can be an intervention, potential intervention for improving the liver quality, but we are not sure. Thank you. Yes, finger crossed.
Andrew?
Yeah, thank you. Thanks for the talk. As a non-liver person, I just wanted to, I guess, make an observation that, after transplantation, I think a small degree of hemolysis is fairly common. I remember reading somewhere that it was up to 30%, and everyone ends up with a very small amount of hemolysis from shear stress, as you have outlined. But there's also anti-red blood cell and autoantibodies that is not uncommon as well. So I wasn't sure how impactful that would be for liver, and whether hemolysis process would impact the ALT and AST. But this is coming from non-liver person, and I was just wondering.
Yeah, thank you for the question. So as you told me that the hemolysis in kidney NMP is presented previously, as shown in this one. It is 2024, quite recent one, but it shows a free hemoglobin increase in kidney normothermic machine perfusion. And we also observed some of the markers during machine perfusion in our cohort. So, for example, one potential marker of hemolysis can be carboxyhemoglobin, which is stated can be a marker of hemolysis, and it increased in lower in livers, these blue boxes. But still, it's tricky because it is also associated with the livers itself. So it is made by the myoglobin and so on. So it is associated with the liver injury itself. And also LDH is a marker of hemolysis, but of course it reflects the liver injury itself. So we couldn't kind of state proof the existence of hemolysis, but we are pretty sure hemolysis should have some effect on this hemoglobin drop. We don't know what extent of the hemoglobin drop was contributed by the hemolysis, but it should be. Thank you so much.
Santosh?
Aki, I was not sure whether I missed it. The source of the donors are all DBD or DCD, or it's a combination of both?
It's a combination of both. And
So did you? So
Yeah,
so did you find
Sorry,
the
I missed.
same results in both? The inferences were from both the groups were similar?
Yes, sorry, I performed the analysis previously, and I think I didn't see kind of significant difference between the groups, but most of the livers perfused at our hospital is DCD, donors after cardiac death. So most of the livers in this cohort is DCD actually, more than half. So
right. So the reason why I asked that question was that, see, in DVD, because of all that brain mush that comes along the cytokine release and all that sort of stuff, has some effect on the organ, I suppose. But is there a proposal for going forward that you would do normothermic regional perfusion and then put those organs onto NMP? Because there is some data now coming out of the Dallas area in the US where they say the strictures and all that, biliary strictures are much less when you do like that normothermic regional perfusion, then bring those organs into the NMP and then transplant. So any project like that coming up?
Well, maybe I will jump in, Aki, because
Thanks.
we can't do normothermic regional perfusion in Australia. We have been struggling with this. Maybe New Zealand will start doing, but we can't do because we can reperfuse. And there was a bit of a debate in the last LITEC meeting about this, but we don't have plans for that. I would say, Santosh, that if we could, if I myself, I'm not talking about the group, if I would pick up one technique, it will be in normothermic regional perfusion. That's the only technique that we know that decrease the biliary stricture, which is the Achilles tendon of these patients.
Yep.
And we did have, and sometimes we do perfuse brain dead, and it's mainly because a bit of logistics. We are running two transplants at the same time, so we do one for the other day, and it's a bit of a playing around. But we tend not to perfuse the brain dead ones. We only perfuse if we have to.
Right. Yeah, just with that same thing, Henry, I know we sort of briefly touched about this in Christchurch. Is this law uniformly across Australia, or is it state-wise? It is different.
Yeah, no, it seems to be our definition of circulatory death, unfortunately. I was going to just ask, because I just assumed these were all DCD donors like Santosh, because you've got a functional warm ischemic time there on that table. So you're confusing us with your table there. if that's a mixture of brain dead donors, because that would be a crucial bit of information if some of them were brain dead donors. We'd really want to know. I was assuming they were all DCD because you've got time from withdrawal to perfusion, then you've got a functional warm ischemia, which obviously is irrelevant if it's a brain dead donor. So yeah, I'm a bit confused by your table.
Sorry.
Are you sure that they're a mixture? Because that would
Yes, there are mixtures. Sorry, these time and functional warm ischemia times or so on things only apply to the DCD donors. Sorry, I removed the footnote, but it is only applied to the DCD donors. So the cohort itself is a mixture of DBD and DCD.
Okay.
Thank you for pointing out.
All right. It's 8:01. If you guys don't have any questions, maybe we should end up here tonight. Well, thank you very much, Aki, and thank you everybody for your questions and doubts and pointing out the things here is very important. And I'll see you in a few weeks' time.
Yeah, great talk, Aggie. Very, very good.
Thank you so much.
Good night, everyone.
Good night.
Good night.
Thank you, Aki.
Oh, thank you so much, Marcus.
Well done.
Bit nervous, but finished. Thanks so much.
Right. You did really well.
Thank you.
See you around.
Oh, yes. See you soon.
Bye-bye.
Cool. Thank you. Bye.
Thank you. Bye.